thank John and Tony and John for inviting me in to do this. So much of the information I'm going to give you, Marik has really set the background for this, and you'll see some of the slides are fairly similar too. So these are my disclosures. So as Marik pointed out, these patients that have in-transit diseases, this is truly a morbid thing for the patients, and I think that we need to have new mechanisms to treat these, and Marik has gone through this very nicely. And for these patients, I think this is actually a slide from Marik. So we tend to share many of our slides. But I think it's also important to recognize that many of these patients may have subcutaneous lesions that are at distant sites. So these are the M1A patients, and they may also have lymph nodes that are not in that regional basin. And I think many of these patients, when they present with that, do not have any other disease. They don't have lung, liver, or brain metastases. So I think these also patients then have disease that we could potentially inject and try to develop an immune response for. Now, Marik went over this also, kind of the goals that we have for this, and I'd like to delineate this a little bit more when we talk about the agents that are currently available. So I think you need to have that local ablative response, but as Marik pointed out, ultimately you want to develop a systemic host immune response in both injected, non-injected, and distantly uninjected lesions. And I think I'd like to look at that a bit more carefully in the studies that have been performed. Looking then at the agents that are in development, so in white here is, or actually in all colors, are the agents that are currently in development. Now this is just a small subset of agents, but this includes viruses, it includes plasmids, it includes small molecules, etc. But the two that I'd like to focus the most on today is the Coxsackie-virus A21. It's also known as Kavitha, but Coxsackie-virus A21 is the currently ongoing phase 2 study. And I also like to focus on telimagene laherparepvec, also known as Tyvek, that completed the phase 3 study and discussed some of those results in more detail. Looking first at the Kavitha or Coxsackie-virus A21. So this is a common cold virus that really attaches to cells that express ICAM1. And melanoma cells tend to have a fairly high expression of ICAM1. So in preclinical studies, they've shown that this virus has the ability to integrate into cells expressing ICAM1. Once they're in the cell, they replicate and then causes lysis of the cell, leading to exposure of tumor-specific antigens to the immune system, and then an activation of the immune system locally to fight the melanoma, but also leads to an adaptive immune response at distant sites. So the currently ongoing study, which is the phase 2 study, this is a 54-patient study, and patients have either stage 3C disease. Now, most of these patients don't have an initial presentation of stage 3 disease, but they've had melanoma in the past, and they now have recurred, so they have in-transit and nodal disease. And so this is, from an AJC staging perspective, the equivalent of stage 3 disease, but from a survival perspective, they are quite different from what you see in the AJCC survival tables. Also included in this is patients with stage 4 melanoma that have at least one injectable lesions. Patients then undergo an injection of a series of 10 injections, and the primary endpoint of this study is IRPFS at 6 months. And if patients have that, they are then eligible to go on an extension study and receive an additional 9 cycles of Kavitha. As part of this study, there was actually a pre-planned interim analysis when 35 patients had been treated to look at the futility of this and see if this treatment was effective. And what I'd like to talk to you about is these 35 patients. Now, looking then at the inclusion criteria, it's fairly standard inclusion criteria that we see for patients with uninjectable studies. So they have to have at least one tumor that is between 0.5 and 1 centimeter, and if they only have one tumor, it has to be at least 1 centimeter in size, and that's so that they can assess it by RECIST 1.1 criteria. Patients are not allowed to have any bone metastases, but they could have had brain metastases as long as they were treated and the patients were stable for 3 months. I think it's important to recognize that in most of the studies that we have in melanoma do not include patients with brain metastases. So the Optimum study, which I'll discuss afterwards, and this study do incorporate those patients. And I think also both Marik and I have treated patients that have had brain metastases, then have an injectable lesion and go on these treatments and have no recurrence in their brain. So I think that it's important to recognize that we need to provide treatments for these patients with brain metastases as well. Now, as part of this study, the patients undergo a serum test for this for the Kavitha antibody, and if they have greater than 1 to 16 on that, they are excluded from this. About 90% of patients do not have that, so the vast majority of patients can go on the study. Now, so let's then look at the first 35 patients that were treated as part of this interim analysis. Currently, there are actually 42 patients that have been treated across 9 sites in the US. And as you can see here in the first 35 patients, about a quarter of them had stage 3 disease, but the rest of them had M1A, M1B, and M1C disease, with actually 23% having M1C disease, so fairly high numbers. So these are patients that aren't necessarily the early patients with in-transit disease and regional lymph nodes only. These were also fairly heavily pretreated patient population with a median of 2 prior treatments for their melanoma. And the patients had received 8.3 injections when this analysis was done. Now, it was recommended then by the DMC to continue the study up to 54 patients because the treatments had been well tolerated. There were no side effects that had been deemed to be the reason to stop the study. Looking then at those specific side effects, we can see that similar to many of the other injectables that we see, these are really well tolerated treatments. So far, no grade 3 and grade 4 toxicities have been seen with Kavitha. Most of the patients have grade 1, grade 2, and the most common effects there being a bit of discomfort at the injection site, some shakes and chills after the injection, and occasional fevers. But overall, it is very well tolerated. Looking then at the response data, now the primary endpoint for this study is to have 10 or more patients with an IRPFS at 6 months of the total 54 evaluable patients. Now this represents then the 35 patients on this study. So when this interim analysis was done, there were 23 patients that had been treated for at least 6 months or been on the study for at least 6 months. And out of those, 8 patients had an CR, PR, or SD as per IRPFS at 6 months. So that's 35%. There were 18 out of 30 patients that had been at least for 3 months, and out of those patients, 60% had an IRPFS. Looking then at the secondary endpoint, which is the overall response rate, we can see that in these patients, that response rate so far is 27%. That's 8 out of 30 patients. 2 patients have had a complete response and 6 with a partial response. I think as part of this study, which is wisely done, they wanted to make sure that at least 3 patients had either a CR or PR out of the first 35 patients, and with this number, this was clearly achieved. Now, there should be some data subsequent to this. There will be some interesting data presented, we hope, at SMR for this, so stay tuned. Looking then at the waterfall plot for these patients, and here you can see that in yellow we have the stage 3C patients, and then in green is the M1A, orange M1B, and blue is M1C. We can see that the CR and PR is about 36% for these patients, and we see responses not only in stage 3C, but also in M1A, M1B, and in M1C. And the CR/PR in stable disease is 80%, and this is assessed by the investigator in the target lesions. So this is again an example of what we see. This is actually one of my patients that had a fair amount of in-transit disease on his scalp, and after 1 injection, all of these disappeared. And this is the fastest I've ever seen with these. Usually, it takes time for these agents to work, and it usually takes about 12 weeks or longer for us to see a response. Once we see that response, the response tends to be very durable. Again, another one of my patients that had a very large bulky disease in his external iliac area that we injected, and he also had multiple other lymph nodes in the same drainage basin, and these lymph nodes were not injected. So again, this shows one of the lymph nodes that decreased in size. Subsequently to this lymph node has now disappeared on the most recent scan that he had last week. We don't see that lymph node anymore. So again, I think indicating that these agents may have a response in those regionally non-injected lesions as well. This is another one of my patients that had a primary melanoma on the left arm, and we injected that and developed in-transit disease. We injected that lesion, but the patient also had a cutaneous, sort of a distant lesion on his left chest. Now, it could be argued, is that from the same lymph node drainage basin? Usually, we don't see that when we do surgery. It tends to go to the axilla, but does not go up on the chest wall. Nonetheless, we can see that in this patient at screening, the lesion was actually fairly small. When we started the treatment, the lesion actually increased in size. And this is not uncommon for us to see with many of these injectables. But then, as we continued the treatment, the lesion went away. And the patient actually came off the study, or went on the extension study and completed the study. And then we did a surgical resection of the primary lesion that we injected, as well as another lesion on the arm. And both of those showed a very small, still some disease, but a very small amount of disease in the injected lesions. One thing we're also trying to determine with this, and Marik sort of talked about this, well, are there biomarkers that we can use? And I think that with many of these, whether it's injectables or other immunotherapies, it's really trying to understand who are the patients that will respond, and are there markers that we can use to try to predict that response prior to them responding. So as part of this study, we're also looking at biomarkers. And what we find here is that in most patients, when we start the injection with Kavitha, there is an increase in both IL-8 and gamma interferon. But in most patients, then we see that those levels seem to decrease after those initial injections. However, at least preliminarily, it seems that in some patients, when they do respond, then there may be an increase in either IL-8 or gamma interferon, marking that they now have a response to the treatment. So again, very preliminary data, but I think at least an attempt for us to try to immunologically and from a serum perspective understand if there are markers that we can use to assess these responses. Now, so again, I think that in conclusion for this specific study from the interim analysis, we can say that this is a multi-dose interlesional study that is well tolerated. It has achieved its interim futility milestone. And we're continuing to accrue, and we estimate the full accrual of this will happen probably in November of this year. The interim IRPFS at 6 months is sort of currently 8 out of 23, which is 35%. And the overall response rate is 26%. And I think we see responses again in both injected and non-injected lesions. And we may have some potential biomarkers that can be followed. Moving then to telimagene laherparepvec, also known as Tyvek. So this is a very interesting virus. It's a herpes simplex type 1 virus that has been modified quite a bit. And the viral factor, the virolytic factor, actually the ICP34.5 has been deleted, so it doesn't produce herpes. But it also has had insertion of a GM-CSF cassette, so it actually, when injected into tumors, produces GM-CSF. And the virus is primarily taken up by tumors. And as seen on these images here, once inside the tumor, then causes viral replication, production of GM-CSF, lysis of the tumor cells, exposure of tumor-specific antigens to the immune system, and then activation of the immune system, both locally and also at distant sites. So this is data from the phase 2 study that was done with Tyvek. And we can see here in this study, it was again patients with stage 3 disease and stage 4 disease with injectable lesions. And we can see that the overall response rate was definitely the highest in patients with stage 3 disease that had a 40% overall response rate. But you do see responses at all, in all patients with distant metastatic disease as well. And the overall response rate from this study was 26%. And if you get a response, that response is actually very durable. So the 6-month durable response rate was actually 24% for this study. Based on this, as Marik also pointed out, the Optimum study was then designed. And this is a phase 3 study, multi-center randomized study that randomized patients with injectable or unresectable stage 3B, 3C, or 4 melanoma to either Tyvek or GM-CSF. It was a 2-to-1 randomization. One of the criticisms of this study has been, why did you choose GM-CSF as a comparator? I think we need to recognize that this study was designed about 6-7 years ago. At that time, there really was no standard to treat patients with melanoma. Many of the newer agents that we have right now were not approved at that point in time. And I'm not sure we still have a standard of how to treat these patients. So this was, again, in discussion with the FDA. And I should also say at that time, there was some indication that GM-CSF may be active in patients with metastatic melanoma. So in discussion with the FDA, this was the comparator that was chosen. So patients then received Tyvek injections, and the primary endpoint of this study was durable response rate, defined as an objective response lasting for at least 6 months. So let's look at the data. So the durable response rate was seen in 2% of the patients on the GM-CSF arm compared to 16% in the Tyvek arm. Again, this was a statistically significant difference in the response rate, the durable response rate. The overall response rate was 5.7% in the GM-CSF arm and 26% in the Tyvek arm. Interestingly, though, if you look at this in the patients in the Tyvek arm, 11% had a complete response. So looking then at the goals that Marik presented also about this, you need to have a local disease control, so you need to have an ablative effect, and Marik has presented some of this. But let's look at Tyvek specifically. Who were the patients that seemed to respond the best? Well, the best responses in terms of durable response was seen in patients with stage 3B and 3C and M1A disease. And these were 33 and 16% respectively. The M1B and M1C, although they did respond, did not have as robust of a response. So Tyvek then, and from the phase 2 study, and unfortunately the way the phase 3 study was designed, it did not necessarily assess the response in injected lesions, response in regionally non-injected lesions, and response in distantly non-injected lesions. Now, we have subsequently gone back to the data, and we're going through the data right now to try to determine if we can find those numbers. From the phase 2 study, though, the response in injectable lesions with Tyvek was 26%. Now, again, unaudited data, we know that in the Optimum study, this response rate is actually much higher. It's over 50% in those injected lesions. How does that then compare to other lesions? Sorry, let me go back. So, well, IL2 and BCG definitely seem to have a more robust response in those injected lesions than Tyvek has. And Iliac 7, as Marik said, is currently out, but I think for historical comparison, it's good to have it there. And PV10 also seems to have a higher response rate in the injected lesions. But ultimately, we want to have that immune response in uninjected regional lesions. And looking at those, we can see that in the phase 2 study for Tyvek, that response rate was 23%, whereas IL2 really has not been shown to have a response in those regionally uninjected lesions. BCG has some response, albeit fairly low. Iliac 7 in the phase 2 study had 19%, and PV10 is about 37% in the presented data. Now, in Tyvek, in the Optimum study, this response rate in uninjected regional lesions is around between 30 and 40%, so it is a bit higher than what we had in the phase 2 study. But what about distant metastases then? So here we can say that patients with the stage 4 disease that had M1B and M1C clearly had lesions that were not injected. The response rates overall in those, in terms of durability, was fairly low. But I think it's important still to look at those lesions and see, did we have responses? You have to remember, this is overall response, may not necessarily represent individual lesion responses. So IL2 and BCG clearly has not been shown to have any response in those non-injected systemic lesions. And in the phase 2 study, the Tyvek response was about 18%. Now again, in the phase 3 data, preliminarily, this response rate is around about the same, about 18 to 20% in those non-injected systemic lesions, and PVT has a response rate of 33%. Marik brought up the concept of a systemic adjuvant response, and here I think it's very important to recognize that one of the mechanisms that we want these treatments to achieve is that patients with stage 3B and 3C disease, we want to treat that disease locally, but ultimately we want to prevent them from ever developing pulmonary or brain or liver metastases. So we want to try to prevent that. And the question is, can these treatments achieve that? And I think we still don't have the answer to that, but that's something that we are looking into and see if they can. Some would argue that they may be able to do that, and this, Marik showed this graph already. This is the interim overall survival analysis, and I think it's important to recognize that this was a planned interim overall survival analysis. And what we found from this, that there was a trend for patients on the Tyvek arm to have an improved survival compared to patients on the GM-CSF arm. Now, we have gone back and looked at what subsequent treatments did the patients receive in the Tyvek arm versus the GM-CSF arm. And patients received pretty much the same kind of treatments afterwards. I think that this is, once we have the mature data, if it shows that there is an improvement in overall survival, I think this is a true survival benefit for these drugs. Now, we also want to have limited toxicity, as we said, for these. And again, this is the data from the Optimum study. Very few grade 3 and grade 4 toxicities. The most common ones happened in 2% or less of patients. There was cellulitis, fatigue, some vomiting and dehydration, but again, very rare to have that. Indications, Marik talked about this. I think that these will definitely be indicated in patients with cutaneous and notable injectable lesions. This is the stage 3B and 3C. The neoadjuvant approach that we said, for us as surgeons, the easiest thing many times to do is to take out patients who have big bulky disease in their axilla, in the neck, in the groin. But ultimately, we know that the risk of failure, as Marik also pointed out, is over 50%, that they will develop distant metastatic disease. So if we can use this initially, provide them with treatment, even if they are resectable, with an injectable for a period of time, try to activate their immune system to develop that systemic response before we do surgery, I think is something that is, would be very valuable to our patients, and we're looking into that through different studies. I think a low burden disease in stage 4 with M1A and M1B, I think these will be indicated. M1C disease, I still think it's questionable. Interestingly though, in the phase 2 data from the Tyvek study, there were a number of patients that had visceral disease that had actually a very robust response to Tyvek. So still think that we don't know enough about this patient population and which patients with M1C disease that may be responders to these injectables. Poor performance status, as Marik also pointed out, I think is definitely indicated. Ultimately, we are going to go to combination therapy, and Marik has talked about this already, and the currently ongoing study uses ipilimumab and Tyvek then, and what patients are given in this, they're giving Tyvek for a period of time to try to cause that tumor lysis and activation of the immune system locally, and then the brake on the immune system is taken off with ipilimumab, so patients are given then ipilimumab afterwards. And many of those infusions are given in conjunction with injection with Tyvek. This is a phase 1B and phase 2 study. The 1B component has been completed, and that data will be presented shortly. And really, there are no new side effects, and it has actually been very well tolerated by patients. So based on that, the phase 2 portion of this is now ongoing. So questions? I think we'll take the panel after John.